Welcome. My name is Michelle Evans. I'm a business finance partner for the Southern Area Local Health Network, part of SA Health in South Australia. I acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respects to their elders past, present and future. I recognise and respect their cultural heritage, beliefs and relationship with the land. I acknowledge that they are of a continuing importance to the Kaurna people living today. I also acknowledge the traditional custodians of the various lands of the people watching this presentation and the Aboriginal and Torres Strait Islander people participating in this conference. In health, the demand for services continues to grow, and technological advances drive change in both the what and how healthcare is delivered. The cost of providing care continues to increase, and organisations need to make decisions about how to best provide the services within their budget. In my role, I use data daily to provide information and to make decisions, but I struggle with the accuracy of what is available. But alongside this, health has a new story to tell: value-based healthcare, where the focus is on the outcomes expected by the patient and the total costs of providing care through the patient's journey. To implement value-based healthcare, we need to rebuild the foundations of our organisations, moving away from the siloed approach to one that embeds the capturing of patient outcomes with a focus on clinical costing. In a simplified system, the foundations of a health organisation are two main building blocks: the organisational structure and the systems that support the running of the organisation. There should be linkages between the systems, enabling data to be exchanged, and underpinning the systems are standards that should be adhered to. In a large health organisation, the traditional structure is usually tiered. It may reflect a collection of wards, which are part of a specialty, a group of which are contained within a division, located in a hospital and part of a larger reporting body. In South Australia, these are local health networks. In other states, they are local health districts or services. Costing data is usually captured at the lowest tier, then collated upwards to provide organised information and reporting at each tier. To support these organisations, a large and complex array of systems is in place. All are capturing different types of data, sometimes only using it locally, at other times pushing it to other systems. All of these systems are telling different chapters of the same story, albeit in different languages, and often relying on manual processes to provide the links between the characters. In health, standalone systems are often purpose-built for a well-defined but singular function. The design and implementation of the new system may be siloed, with little thought to how the system will exchange data. From these systems, these are the types of questions that we can answer. In a hospital system, the finance system shows us how a ward is performing against budget. The nursing roster system tells us how the ward's been staffed. Payroll will tell us what it costs to staff the ward. And activity will tell us how many patients have been discharged, how long they stayed, and the value of their stay. But let's look at this from a patient journey perspective. Consider a patient who presents to emergency and is diagnosed with a ruptured ACL. They then see a doctor in an outpatient clinic and are admitted a few days later for surgery. Along their journey, costing data is captured in the silos that the patient steps through: an ED visit, an outpatient appointment, blood tests, x-rays, a procedure in an operating theatre, a ward stay, pain relief and extensive rehab afterwards. The current foundations are not set up in a way that enables us to look across these systems and to tell the story of the patient's journey. And in many areas, there is simply no data on the patient once they're discharged from hospital. Value-based healthcare merges two pieces of information: the costs across the full cycle of care and the measure of the outcomes that are important to the patient. Using the patient example from above, value-based healthcare would capture the cost involved across the patient's journey from ED to rehab, and then measure the value of the outcomes achieved. The outcomes will be different for each patient. The professional sports person has a well-paying contract for another 2 years that they want to see out. The carpenter needs to be able to climb ladders all day to continue working. The retiree wants to resume their daily walks on the beach. Outcomes are what is important to the individual, and we need to measure how well the care provided enabled this to happen. So here are my 4 primary reasons to rebuild the foundations of our health organisations. It will take time before the benefits of a rebuild will be seen, and there will be many challenges along the way. The sheer number of systems involved, both internally and externally, and the extraordinary difficulties involved in getting stakeholders to talk to each other may be seen as a valid reason not to make changes. It's just too hard is an excuse I've heard many times. The first reason is data warehousing and governance. SA Health has a 3-year plan to implement a statewide data and analytics platform with the intention to make sense of the various data warehouses across the state. A key outcome will be to modernise the technology ecosystem. In order to maximise insights generation and delivery, it is important to leverage a fit-for-purpose suite of enabling technologies. This could include a data lake for unstructured data and a virtualisation platform for consolidated analytics combining data from various warehouses. The second outcome will see data treated as a strategic asset. Effective data governance underpins key business capabilities and ensures that the benefits from data, analytics and insights are realised while ensuring the risks are managed. This will be a difficult task with a large number of stakeholders to manage. Statewide data standards will be integral to the success of this platform, meaning that each organisation involved can't develop their own. And so any rebuild at a local level must be done in awareness of and in conjunction with SA Health. The second reason is really simple. Garbage in, garbage out. If we don't rebuild the foundations and if we don't update and maintain the systems, then regardless of what data we're capturing, it won't be useful. It certainly won't enable us to measure the value of what we're doing. And in a reworking of what may have been said by Redicus in the 1500s, you can't change what you can't measure. Here's a classic example of a problem I have when trying to connect data from different systems. The financial cost centre is an essential field in any data system involving costs, a simple numerical code used to identify a unique area within the organisation. Yet in 4 systems, there are 4 different data structures for this code. Even a simple VLOOKUP won't work, and raw data must be manipulated before any cross-system analysis can be undertaken. Another major issue we have is data mapping. While some data is automatically captured through the nature of the transaction and some is manually entered, a large portion is system allocated using mapping tables or algorithms. These tables and algorithms need, but rarely get, constant review to ensure they reflect what is happening with the organisation. The internal structure of our organisations changes over time. Wards are often repurposed to another specialty, or a new site is opened and an entire service relocates. Mappings are often not maintained to reflect these changes, and data simply goes to the wrong place. In this example, a standard monthly report would indicate that Ward C is not efficient. It's simply costing more than the value of the activity generated. Time and effort will be spent investigating, questions asked about why the salaries were so high, rosters would be investigated and overtime looked into. Patient records will be interrogated and the usual rumblings as to whether the stay was coded properly will be heard. But the problem is simply that the mapping tables are wrong and the data isn't being allocated correctly. The third reason to rebuild is intelligent decision making. Anthony Liu added a new I, intelligence, into the well-documented DIKW hierarchy to become DIKIW. Intelligence adds the capacity to learn, conceptualise, analyse and make decisions and needs to be a critical part of data analysis for strategic decision making. To inform intelligent decision making in health, we need to link costs and patient outcomes together. Only this will enable value-based healthcare to be made. Here are just some of the questions that we in health ask ourselves now, but have no way to answer. We have access to lots of data, but the key is summarising the data information from which to create insights. If we rebuild the foundations, then we'll be able to ask and answer these questions, and many more. In conclusion, in order to make better decisions about the care that we can provide to our patients, we need to rebuild the foundations of our organisation. We need to ensure that our systems reflect the structure of our organisation, that there is data integrity, and that data can be shared. Critically, we need to embed the capture of patient outcomes into standard clinical practice. Only then can we start to tell the new story, not about wards and divisions, but about the value that has been provided to patients through our care. Thank you.